فاحنا النهارده ده سيمبوزيوم هيتكلم على different situations, different cases in cataract surgery, and it is very important to try to learn what are the tricks and when to use it. للاسف الدكتوره نانسي رقاد اعتذرت لظروف خاصه يعني فمش تقدر تيجي، فعشان كده احنا giving some time ان احنا هنبتدي، بس هنبتدي دلوقتي. الدكتور اشرف كمان جه اهو كويس يعني. هو الريموت، انا بس عايز الريموت.
بالظاهر انه
هندي دقيقتين كمان كده اهو. السيشنز الثانيه متاخره.
بتحب نتستنى شوي؟
ممكن استنى دقيقتين يعني
طالما هنتاخر ونتاخر على بعض
يعني ممكن يعني نستفيد الوقت بتاع الدكتوره نانسي ان هي مش موجوده، فقصدي يعني ورست كيس سيناريو.
Introduced my dear friend and the moderator of this session, Professor Yahya Salah. He will speak about posterior capsulorrhexis. Please, Doctor.
Assalamu alaikum. This is a topic that every cataract surgeon هو مش شغال ده. It's not working. Okay. This is a topic that every cataract surgeon should know it. Whether you work pediatric, you work adult, you have situations that you need to deal with the posterior capsule regardless of your background. And sometimes there are complications that you need to manage. And the aim is at the end is to get the patient in the best visual acuity. The posterior capsule, we know it's very thin. It gets thinner. It gets thinner the older we get, وبالتالي you should be very careful, but not too careful. So what do you do when you have at the end of the surgery cells on the posterior capsule that you need to clean, or you have a membrane on the posterior capsule and you want to clear it, not to wait for YAG capsulotomy later on? Its video is not working ليه؟ ده كمان يعني. Play this video. طيب ماشي. Play this video. So you see the cells in the posterior capsule. You first try to wash it. You try to wash the posterior capsule with jets of fluid. This will clean the posterior capsule perfectly well. and if it doesn't clean, then you have to resort to other techniques. Play the video. So you can be faced with a very simple, in every case we can clean the posterior capsule with washing, but here I'm trying to wash, it doesn't wash. Then if you work with good magnification, you can see that actually there is a membrane over the posterior capsule that you can peel off the posterior capsule. I'm not doing posterior rhexis up till now because I can peel it over the posterior capsule. And you can see the wrinkles in the posterior capsule. The objective is that if you know how to work on the posterior capsule, you will be more courageous to deal with this without waiting for a YAG capsulotomy with the inconvenience of the YAG capsulotomy in some cases. So when do you need to do posterior capsulorhexis? Primary posterior capsule opacity, like this one if I fail to peel. In congenital pediatric cataract, this is the routine. Young patients, in general, particularly if you are using multifocal intraocular lens or you are managing complications. The idea that I want you to learn and know about that the posterior capsulorhexis has a technique that should be reproducible, and you can do it each time in the same way. So you are confident that you get the result that you want. You want to make an opening in the posterior capsule without insulting the anterior vitreous face and losing vitreous. So you make an incision in the posterior capsule, inject viscoelastic to push away the anterior vitreous face, then you inject another bolus in front of the posterior capsule, so you have the posterior capsule as if it is sandwiched between viscoelastic. So your force is the only working force to tear the posterior capsule. Once you finish the posterior capsule, then you can remove the viscoelastic after implanting the intraocular lens. So let's look here. You see an incision, viscoelastic injected, pushing away the anterior vitreous face, and under complete vision and complete control, you tear the posterior capsule into a circular rhexis that you can enlarge, make it the size that you need. The most important thing in this technique is that you learn how to do this without fearing to open the anterior vitreous face and getting vitreous loss. And then you implant the lens in the capsular bag. And you have to remember, once you open the posterior capsule with the posterior capsulorhexis, the way you think how to inflate the bag before injecting the intraocular lens should differ. You have to inject in multiple areas because it is not a continuous bag anymore. Once you open the leaflets, you can inject the lens into the capsular bag, and it's going to be very stable, very well-oriented. Just make sure you don't go into the posterior rhexis with the first haptic, whatever the type of intraocular lens you are using. Can you play the video? Bashmandas. Can you play the video? You can't? Okay. You see, the same technique. I'm going to show you a sequence of cases that you see that it is very reproducible. Once you understand the concept, you can do it 100 times the same way. Incision, viscoelastic, pushing the anterior vitreous face. You can see the bubble of the viscoelastic. Widening the rhexis. If you see that you cannot hold properly the capsule or it is going to extend, just stop, inject some viscoelastic to restore the condition in front and behind it, and then continue the capsulorhexis. Again, injecting viscoelastic in different points to inflate the remnants of the bag, then you can very confidently inject the lens, any type of the lens, between the leaves. And this is a technique, is the routine technique in children. In very young children, maybe you can add doing anterior vitrectomy through this capsulorhexis. You see, you can rotate, don't worry, because it's a continuous opening in the posterior capsule, so it's not going to extend. Using viscoelastic is very, regardless it's methylcellulose or not, or I mean visco-cohesive or adhesive, it doesn't matter. Sometimes you prefer to use visco-cohesive to push better the anterior vitreous face, but it really doesn't matter. Once you learn the technique, you can do it. Make sure you don't get bubble like this one. It's the same technique. يعني the best way to learn difficult maneuvers or any technique is to know what is behind, what is the rules behind it. So you know when you are doing it, you have a very steep learning curve. I injected viscoelastic again. Okay, if you have a complication, you can have this problem. Can you play the video? I'm washing the posterior capsule. This is the only time during washing I open the posterior capsule. You can have the same problem doing irrigation aspiration, have the same problem doing phaco. So then if you have a tear in the posterior capsule, if it is not circular, you have to turn it into circular opening. So as you can either continue irrigation aspiration or implant the lens in the back. This was at the very end of the surgery. So I followed the same rules, which is inject viscoelastic, push away the anterior vitreous face, viscoelastic in front, and convert this tear into a circular one, so it will not extend. So although you can have a complication, but if you understand how to manage it properly, the outcome at the end will be exactly the same. You see, if you train yourself, you can do it each time in the same way. And I converted it into a properly sized posterior capsular access. And then I can fill the bag with viscoelastic in different points and implant the lens in the capsular bag with no consequences. So the posterior capsule, everybody is usually afraid of the posterior capsule, but actually you should not once you learn how to deal with it. One of the tricks that is very important, I think, is to learn during your regular training or surgery to work in high magnification. If you work in high magnification, you can really deal with the posterior capsule with ease and comfort because you can see everything. So this is just a repetition to show you in many cases you can do the same technique successfully each time you intend to do a posterior capsular access. Okay, thank you for your attention. And we can have maybe 2 minutes because I finished early. We can have 2 minutes for if anyone wants a question. Yeah.
Please, Dr. Ashraf.
If it's one piece IOL, I don't go direct inside the bag. I put it above the iris, above the anterior capsule, then take the first haptic inside the bag and the second haptic inside. Some are afraid that you can go, if you inject, you can go directly behind the posterior capsule.
It's a good point, but if you learn how to work in high magnification, and if you're using particularly hydrophobic acrylic, so hydrophobic acrylic unfolds very slowly. So actually it's much easier and less manipulation to implant the first part, and usually the haptic is bent, so it will go inside the capsular bag and it will be easier. But it's a good point. If you're not comfortable doing this way, you can do this way, of course. And if the pupil, I do this way, if the pupil is very narrow.
Yeah.
Anyone has any question? هتعملوا posterior capsular access؟
سويت طريقة مال الامبلانتيشن اللي يصير عليها خليتها؟
مفهوم؟
Have you done posterior capsulorhexis?
No, it was a rupture يعني during surgery, accidental rupture, and I put the IOL in the same way that you.
But Yahya, he said that when this happens, this also is happened in yeah accident. Yeah.
Excuse me?
For what?
One question,
Yes,
please.
actually, in young high myopes, you can do it. And the rationale behind it, first of all, if you don't interrupt the anterior vitreous phase, you will not get increased cystoid macular edema. And if you don't interrupt the anterior vitreous phase, there will be no traction of the retina. And the counterpart of this, doing this, is doing YAG capsulotomy. And YAG capsulotomy, there is an incidence of inducing retinal breaks from vitreous traction during YAG capsulotomy.
Excuse me. One question. Is it better to overfill the bag or no with viscoelastic?
I'm sorry, what? What's?
Is it better to regarding viscoelastic? Do you prefer to overfill the bag with viscoelastic or no?
While doing or while
While
implanting?
doing, before doing.
Don't overinflate,
That's
but
it. Yeah.
the idea is the first step is that you make the incision, and then you want to separate the posterior capsule from the anterior vitreous
Yeah.
phase, and there is potential space, Berger space.
Yeah. And is it different to do it after implantation? That some surgeons they implant the lens, then they try to.
Yes, there's some people do this,
Yeah.
but the idea is they are usually afraid to do the technique. So
Yeah.
they say, if I complicate the lens is in place,
Yeah,
but
it is-
if you follow the rules of the technique, it's almost impossible to get a complication unless you lose one of the rules of the technique. It's much easier, of course, to do it before implanting the lens.
Okay, thank you.
Now we will move to an interesting case. Dr. Ashraf Armeya will talk about weak zenules, post-Ahmed valve, and vitrectomy. Until we fix it, if still you can have a.
No, it's not working from there.
Yes.
Pointer. Where is the laser?
Working? Yeah, why I would change in
Decrease the magnification to have more depth of focus. So in high myopes, would you do, if you have a PCR rent with high myopes, would you do the same technique? Like high magnification as well?
Yes.
Oh, okay.
يعني the idea is most of the people are not used to work on high magnification. But if you teach yourself that you work on high magnification, and this is my advice always, and in the section of when I give a course about preventing complications, I put this one of the things preventive, because you can see in the normal cases what's happening, and when you have a complication, you can see it very well. If you are trained and teach yourself to work on high magnification, I think, in my opinion, it's very useful. Of course, the very good surgeons doesn't do this also.
But in high myopes, we always try to decrease the magnification to have higher depth of focus while you're doing erexis. This is the technique that I was taught. So you can switch when you have a PCR rent to high magnification.
Yeah, I don't understand what is the correlation between high myopes and the magnification.
It's more difficult to manage in high myopes when you have a high magnification. You
You
decrease the
mean because the
magnification.
anterior chamber is deep
Yes.
and you can focus down?
So during only this step, then you can switch from low magnification to high magnification, right? That's the. Okay.
هو هيقعد هناك يعني؟
الكابل مش
بس هو بينقل.
الكمبيوتر بتاعي هناك.
Okay, go ahead, Dr. Ash.
Okay. مساء الخير. Good evening. Thanks for Dr. Yahya for the invitation and Dr. Abdulaziz Badla. So this is a weird case. It came to me since 6 months now. I'm following the patient. And it was subluxated after Ahmed valve. So it was a male patient, 52 years old, done retinal surgery, retinal RD surgery and he did a vitrectomy, and now he's on a fluid. After the vitrectomy, he developed increased intraocular pressure, and he referred to the glaucoma specialist, and he did an Ahmed valve. As we see, it's very nice. The IOP is perfect, controlled, but he developed a cataract, nuclear grade 3, and he's now for surgery. So very important that you keep the integrity of Ahmed valve working after cataract surgery. So we, during the operation, this is what happened. As I start to do the rhexis, I found that I touched the anterior capsule, it was like this. So I discovered that this is a subluxated also lens, maybe subluxated, maybe zonulosis, maybe there is no support from inside. So, and you cannot, this is a complicated case. You don't lose the capsule easily. So what I did, can you play the video, please? Can you play the video? Can you play the video? Okay. Okay. So this is Ahmed valve. I should keep the Ahmed valve working. And this is what happened. So my aim when I started this, that I'm going to do a very nice anterior capsule because I'm going to use this anterior capsule by all means. So it was central, not very large, and circular, and central. So this is what I achieved. So I was happy like this, so everything is fine. But during the hydrodissection, we are going to see now, during the hydrodissection, the wave is perfect, but during rotation now, see, okay. So we have nearly 1/3 of the zonules up is subluxated. So I decided directly before I go for phaco, I put the capsular retractor from MST. I used only 3, but I choose where I'm going to put the capsular retractors. So I put one here, there is no, and the other one in the middle, and the third one like this. And you should obey during insertion of the MST the bend curve, during insertion and during removal of the capsular hooks. So now I am supporting the area of subluxation. This is very important because you should keep the integrity of the bag. And I did a visco expression of the nucleus outside the capsule because I don't need any traction in the capsule. And this is not so hard for me, so it was okay. So I succeeded to finish it as early as possible, but before you go out in these cases, never go with your phaco probe, inject visco dispersive, very important, not to increase the integrity of the zonules. Also during the IA, in these cases, you don't have a back support, you have a zonules weakness, and you should not be hurry in putting the CTR in these cases because it will make the removal of the cortex difficult in these subluxated cases. So take your time, it will going to come easily, and I finished. Any cases of like this, you should put a CTR before you continue and before removing the capsular hooks. And this capsular hook is a modified chunk that the CTR will not going to entangle the capsular hooks. So in this case also, I use the CTR. It is not the injectable one, it is the manual one. And during insertion, take care you pass the area of the subluxation first. I did a small mistake that during insertion of the CTR, I left it early, so the CTR is above the capsule now. So easily, you can again insert it in the bag, very easily. And now you see the capsular hook is central, and you put your single piece, removal of all viscoelastic in these cases, and you should not leave any OVD in the anterior chamber because of Ahmed valve. It can be blocked. I didn't irrigate the Ahmed valve because during the IE in the last maneuver, I found that the PLIP is increasing, so the fluid is passing through Ahmed valve to the area of conjunctival. I finished everything, and it was completely done. And this is how it looks post-operatively. A very clear cornea, the Ahmed valve is working good, and the pupil is round and regular. So my home take message in these cases, proper history of your patient, because this is a multiple history for the patient and multiple operations. Should plan yourself. Expect everything in complicated cases. And vitrectomized eyes on a fluid leads to unstable bag, especially in high myope, and it was a high myope. Capsular retractors are a safeguard for subluxated capsular bags, and CTR is mandatory to stabilize the integrity of the bag and the centration of the IOL. Thank you so much.
Thank you, Dr. Ashraf. Do you have experience with Henderson capsule tension ring?
Yes, the one with the serrated, I used once, but I don't have a lot of in my hands.
This is a new design of capsule tension ring that help you to do irrigation, especially of the cortex, if you need to put it early without disturbing you. But if you don't have it, if you give me a chance to add a comment, at the time, if you are afraid that you find that the zonules coming and you don't have the capsule tension ring, the capsular hooks, because this is a very good idea, because it makes you work in a very safe environment. One of the things is just to splash the cortex, so you'll make it loose. Even if you put the capsule tension ring, it will be easy to remove it. So,
it's for more share, and if you want to buy a lot, you should buy now, because this company, I think, after the new regulation of the CME, I think this company will not going to continue.
No, I don't want.
Yeah, so I have a comment for the cataract surgery after the vitrectomy. Always we have to take care that the anterior chamber is not stable as if the patient has a vitreous. Yeah, so
Yes.
We have to look for the fluidics and decrease the vacuum and the irrigation height. So always after the vitrectomy. Yeah.
Yes,
Yeah,
that's
yeah.
true. Yes.
Thank you, Dr. Ashraf.
Yeah. Our next speaker is Professor Muhammad Husni. He will speak about premium IOL implantation after corneal refractive surgery. Please.
So, good afternoon, everyone. It's not a packed room. Okay. So my presentation today is regarding premium intraocular lenses in special situations. Okay, factors for success in premium intraocular lenses, and when I say in premium intraocular lenses, I mean trifocal intraocular lenses, EDOF intraocular lenses, and of course trifocal toric intraocular lenses. The factors for success for any multifocal intraocular lens is patient selection, preoperative measurement, biometry, and corneal topography. Corneal tomography should be done to all patients that are going to be, or you plan to implant a trifocal intraocular lens in. Very, very accurate IOL power calculation, surgical technique, healthy anterior and posterior segment. But the problem with premium intraocular lenses, premium multifocal intraocular lenses, is that a lot of KOLs who speak about trifocal intraocular lenses make it appear as if you need to have a perfect eye, a perfect Gulch-Strand eye in order to implant a trifocal intraocular lens. And the contraindications and the hiccups and the things that you should not the patients that you should not attempt implanting trifocal intraocular lenses in are becoming more and more and more. And I think this this is over exaggerated. We learned this. We implanted trifocal intraocular lenses in many situations that were a relative contraindication with very satisfactory results over and over and over again. So this presentation will emphasize the contraindications that are not super important. So what is the best candidate to start trifocal intraocular lenses in? Emmetropic patients, hyperopic patients, of course, they will be very, very satisfied postoperatively. Patients who are dependent on 2 prescriptions, and by saying this, we all have the occasional hyperopic patient that does not wear spectacles for far and who comes seeking reading spectacles, and when you tell them that he needs spectacles for far, he's like, no, I can see good, and when you put the +1 or +1.5, he says, oh yeah, that's better, but I will not wear it. So these are not perfect patients to start trifocal intraocular lenses in. If the patient is dependent on 2 prescriptions, then he will definitely appreciate the value of the trifocality when you pop in a trifocal intraocular lens inside the eye. Accepting to wear a weak reading aid. Never promise the patient that he will not be wearing lenses postoperatively. If the patient has less than 1 diopter of astigmatism, but again, this is a very relative contraindication. We have implanted premium multifocal intraocular lenses in patients with significant astigmatism. If you can tackle the astigmatism intraoperatively and the patient becomes less than 1 diopter of astigmatism postoperatively. If preoperatively is more than 1 diopter, you can go ahead and do your planning as usual. If he has less than 250 microns of angle kappa, again, we have known repeatedly that, and with studies that I will show right now, that angle kappa is not that important as we thought. But this is the best candidate. If you're doing your first trifocal intraocular lens, then choose one of those, all of these things in your patient, and willing to do the other eye in the near future. We all know, I always tell my patient that however, the medicine now is advanced, it cannot provide you with vision that is a good vision of an immetrope 20 years old. You cannot do this. I'll give you the best result ever, and this best result will be accentuated when you have both eyes implanted with the same lens, because each one will give you something and both of them will give you everything. So premium intraocular lenses in special situation. If you have a patient with large angle kappa, when we started measuring angle kappa in our cataract patients, we discovered, at least where I work, is that more than 60–70% of our patients have angle kappa more than 500 microns. When we started measuring angle kappa with the eye trace in our patients that are supposed to have phacoemulsification. So if you have a patient with large angle kappa, is angle kappa that important? This is what I will discuss right now. And again, what is the most challenging patient? What is the patient that you should not start doing trifocal intraocular lenses in? Patients with very large angle kappa, patient with an advanced cataract in one eye, with not so advanced in the other eye, so we will postpone the other eye for like 6 months or 1 year. Patients with large cylinder, and patients who refuse to wear glasses at all. So this is angle kappa. Angle kappa has been on vogue for the past like 10 years in refractive surgery first, and then in cataract surgery because of the trifocal intraocular lenses. Angle kappa basically is the distance between the visual axis and the center of the pupil and the optical axis. And this distance can be expressed as angle kappa or as chord mu. So should we consider angle kappa when planning to implant trifocal intraocular lenses? You will hear again and again and again and again that yes, large angle kappa, more than 400 microns, if you implant a trifocal intraocular lens in, the patient will not be satisfied, and these are the patients where you might explant the trifocal lens. Steve Schallhorn and Julian Stevens and Amar Agarwal actually was the first one who reported the effect of angle kappa on the results of trifocal intraocular lens. How much displacement would you accept for a trifocal implant, and do you care for horizontal or vertical displacement? Everyone now, there's a common consensus in the field that angle kappa should be really considered if there's a horizontal displacement more than a vertical displacement. This is how we measure angle kappa, and as you can see with the eye trace, it gives you exactly the angle kappa and the angle alpha. And this is a patient with intermediate angle kappa, not very good and not very bad, and this is a patient with very high angle kappa, more than 600 microns. And this was the very first publication by Amar Agarwal that actually made us notice angle kappa, and who reported that angle kappa can really affect the result of a trifocal intraocular lenses. But then again, other publications came by. This is a very famous publication that was done in a joint study between a Chinese university and Northwestern in Chicago. And they actually reported changes in angle kappa, preoperative and postoperative phaco. So you measure angle kappa preoperatively, and then this angle kappa that you relied upon and you made all your planning on changes postoperatively, and this happened in most of their patients. Again, Carrie Solomon in the Storm Eye Institute in Carolina did another study who reported that angle kappa basically does not have, the magnitude of preoperative angle kappa had no apparent effect on the refractive visual acuity, subjective quality, and clinical outcomes with the trifocal intraocular lenses. Again, angle kappa is debatable. I'm not saying that you should implant trifocal intraocular lenses or premium intraocular lenses, very large angle kappa, but again, this is not a very strong predeterminant when you're planning for a trifocal intraocular lens for your patient. Okay. Premium IOLs have been preached not to be used in patients that had previous refractive surgery, especially previous LASIK. So what is special in post-laser refractive surgery? We all know that classically, this is a very common question in ophthalmology. If a patient had a myopic LASIK, then there will be an underestimation of the central corneal refractive power. So it will be an underestimation of the estimated intraocular lens that you're going to implant. And so the patient will end up with a plus refractive surprise. So even if this happens, if putting a trifocal intraocular lens is actually a safeguard rather than a complication, because imagine if you put a monofocal intraocular lens and the patient becomes, or the refractive surprise is a +1 or +2, this patient will not be able to see far, intermediate, or near. But if you implant a trifocal intraocular lens, then at least the intermediate distance can be used for far, and the near distance, the near focus can be used for intermediate. So it's actually, it gives much better vision post-operatively in post-myopic intraocular, post-myopic LASIK if you have a refractive surprise. The recommendations that we use, we actually aim for mild hyperopia. So we are aiming for a hyperopic surprise even in patients who never had refractive surgery before. So ending up with a +0.5 to +1 is not a big deal when you have a trifocal intraocular lens, plus the fact that this does not happen with modern formulae. Okay. The other thing that people were a little bit wary of when implanting trifocal intraocular lens, again, is angle kappa, because Uzwin postulated that angle kappa differs or changes after you do a myopic laser refractive surgery, corneal refractive surgery, and studies have shown, repeated studies, not only this one, that angle kappa remains the same and does not change after laser refractive surgery. So would you recommend a trifocal IOL for a patient that underwent LASIK? Again, I'm saying that it is not a big deal unless you have an irregular cornea. So the main predeterminant is the regularity of the cornea. If you do have a distorted cornea, if you have a patient with starting ectasia or decentration or multifocality of any sort, this will definitely interfere with the multifocality of the trifocal intraocular lens, and you will end up with a non-satisfied patient. But if you do have a patient who has a perfect cornea, very good smooth ablation, central ablation with a wide optical zone, then go ahead and implant a trifocal intraocular lens. I don't see any contraindication at all. Again, there has been studies and publications that reported, this is the Baviera, the founder of the Baviera chain, Spanish chain, and they had a big cohort of patients who had trifocal intraocular lenses implanted post-refractive surgery and reporting very good results. Conclusion, trifocal intraocular lens implantation after photorefractive surgeries in eyes previously treated with myopic ablation achieved good visual outcome. So I had this patient who had referred to me from one of my colleagues, and he actually implanted a trifocal intraocular lens in a patient who had previous LASIK, and the patient was not happy. Okay, so she was a lady. She had a trifocal intraocular lens implanted in both eyes, and one eye was very, very annoying for her. And he referred her to me. He told me, "You're telling us to implant trifocal intraocular lenses in patients that had LASIK before, and this patient had a LASIK before, implanted a trifocal intraocular lens, and she's not happy at all. So solve the problem." And in this patient actually taught me a lot of things, because she had one eye she was satisfied with, and the other eye she was not happy with. And the eye that she was satisfied with had a large angle kappa. So the angle kappa was nearly 600 microns in a previous refractive surgery. So high angle kappa, previous refractive surgery, with a trifocal implant, and she was happy. She didn't have any problem. And the other eye, in which she was not happy, not only she had a good angle kappa, much better than the other eye, but she had a decentered ablation. So it's all about the centration of the ablation and the corneal quality. If you do have a good corneal quality post-laser refractive surgery, then you can go ahead. This is one of the patients that proved my point, that if you do have a large angle kappa and LASIK, you can implant a trifocal intraocular lens if you have a good cornea, but if you don't have a good cornea or a good central ablation, then don't do that. The other condition in which is debatable, would you recommend trifocal in the pediatric age group? This is something that has not been answered yet. There hasn't been a cohort of patients doing trifocal intraocular lenses in youngsters who had congenital cataract. And the reason for this is that, of course, it makes a lot of sense that if you give them this depth of focus, then you will decrease the stimulus for amblyopia. But again, there are other stimuli for amblyopia, like the amount of light energy that is distributed between the near distance, the intermediate distance, and the far distance. If they're using the near environment all of the time, this will have like 20% of the light intensity directed toward the near focus. Is this good for? Will this promote improve amblyopia, or would it increase the amblyopia? No one knows now. I think anything that will be aimed at the near foci, at the intermediate foci or the intermediate distance is much more beneficial for these kids, for the very simple reason that the eye will get larger, and of course the refractive error will change, and the intermediate focus will change into a near focus, so at least he will be safe and dry in the intermediate and near. So EDOF lenses are much better. Trifocal intraocular lenses with intermediate focus predominance, like the Triumph, is much better. There's the Well Fusion system, in which the Meaco Sifi is an Italian company. It has two lenses, two trifocal lenses, the Meaco and the Meaco Proxa, which gives you more near vision. And the Well Fusion system is implanting a Meaco in one eye and the Meaco Proxa in the other eye. I think there is a study going on evaluating or auditing and appraising this technique in congenital cataract. Okay, if you have a patient with formed furostic keratoconus, starting formed furostic keratoconus, would you implant a trifocal intraocular lens in or not? I haven't done that ever, and according to what I'm saying, this is an irregular cornea, so you should not implant a trifocal lens. Surprisingly, there are studies, this is the classic teaching, that trefoil and quadrifoil would produce halos and glare. Dry eye, because of the keratoconus, would produce more higher order aberration. How much trefoil, quadrifoil, premium multifocal intraocular lenses really induce? This is a classic teaching, okay? There is a number of studies evaluating implanting trifocal modern intraocular lenses in patients with documented keratoconus and reporting good results. And this is a study that has been done on patients with keratoconus implanting the AT LISA, and it concluded good results in these patients. Yeah, it's a small cohort, but it reported good results. Trifocal AT LISA provided appropriate distance, near and intermediate visual results. Prediction of refractive results and optical performance were good in keratoconic patients. So in conclusion, I think premium intraocular lenses are gaining ground in cataract surgery. I think around the corner, one day we will not find except premium intraocular lenses to implant. The associated visual inconveniences have decreased significantly. They are not like the good old bifocal intraocular lenses that we used to implant. Patient selection is really not rocket science. In our local market now, we have a battery of choices. We have a lot of trifocal intraocular lenses in our markets. And classic contraindications are being more and more challenged as new generation premium intraocular lenses are much more forgiving. Thank you so much. This is a slide that I like so much. This is how I counsel my patients that are coming seeking trifocal intraocular lenses. I always keep the patient emmetropic or slightly hypermetropic postoperatively. I avoid post-operative, and post-operative means post-operative. The patient has more than one diopter of astigmatism preoperatively, and I can tackle it either with an obstacle coronary incision by planning my incision site, or even by doing an astigmatic keratotomy, or even putting a trifocal toric, then I will do that. Avoid angle kappa more than 0.7, and these are really a small amount of patients. And cover your patient with the Alcon trifocal intraocular lens. And Alcon, this is just a synonym for me to remember. Adaptation of the trifocal implant takes some time. You should tell the patient this. He will need light glasses. There's no continuity of vision, so there is far, intermediate, and near, but in between is a little bit blurry. The other eye should be done ASAP, and night halos can be there, but they are never handicapping. Thank you so much.
Thank you, Dr. Muhammad. يعني very good elaboration. دكتور أحمد غنيمة على بال ما يستعد. we will ask بس على بال ما الدكتور أحمد يبقى بيستعد يعني. لكن we have questions. دكتور أشرف. دكتور محمد البوينت المهمة اللي هو أنت يعني وضحتها ال proper cornea ablation. This is a يعني crucial point.
Crucial.
And then how do you if the cornea is good, the biometry do you have يعني certain multifocal يعني trifocals, certain IOL, we have many types. Is there one that is a little bit forgiving, the other is not forgiving a biometry error?
The Barrett is very good. You mean different intraocular lenses or different formulae?
Different the formula, most of the people will use the Barrett.
Okay.
But still, you can get off target. So, there is a type of intraocular lens that is more forgiving than others?
Okay. Now, I don't want to be any supportive to any manufacturer.
Really?
But yes, the answer is yes. Some of the trifocal intraocular lenses, they have the central part, the central monofocal part, wider than the others. If you have a central monofocal part, 0.9 millimeters or more, this will definitely be much more forgiving if you have large angle cup. Okay? Some of the IOLs are like this. The very famous one is the Acriva Trinova. It's a Turkish brand. It has the widest central monofocal area. The other thing is, it has been shown that some brands are much more forgiving and much more they give much more better results. Of course, the EDOF lenses. The EDOF lenses are very good, including the refractive EDOF. The refractive EDOF. They are also much better. Much more forgiving.
Dr. Hosni, I have two questions. How the pupil size decide which premium IOL you are going to use? Secondly, the pupil size change usually after cataract surgery.
Sorry?
The pupil size always change after cataract surgery. So the angle kappa also will going to change, and the angle alpha. So how you predict the changes in choosing the type of premium IOL?
Okay. Now, just a quick comment about on your second remark. If the pupil size changes, Ashraf, angle kappa does not change except if you have a centroid shift. Okay? So if the pupil size, when it contracts eccentrically, then definitely angle kappa will change. But normally, in most people, angle kappa does not change even if the pupil size changes a little bit. Again, this is something, these are one of the, this presentation is much longer than this. We have high astigmatism, we have subluxation, and we have large pupil sizes. But again, there are studies that showed that we are overemphasizing the pupil size and which IOL to target. For example, if it is pupil dependent or not, like the Physiol or the Panoptics and the debate between. It is important, but it's not that important. It's important if you have a super large pupil size or a super small pupil size. Definitely, if I have a very small pupil size, I would resort to an EDOF lens, definitely, because I will not be benefiting from the diffraction areas at all. And if I have a large pupil size, then I will definitely not implant the lens that is pupil dependent. But again, these are patients out of the norm. These are not the regular, everyday patients that come. I'm saying this because I think we are underservicing some of our patients that demand or ask for trifocal intraocular lenses, and we are like searching for a reason to say no. While these patients, if we implant a trifocal intraocular lens in, they will be very, very happy. The trend in some European countries, for example in Spain, is that they implant trifocal intraocular lenses in more than 50 to 60% of the patients. And from our Spanish colleagues, we know that a lot of patients that we would not have implanted, for example, OSD, if you have a patient with a tear breakup time less than 10 seconds, we do not implant. They do implant, and they do not report a big difference in results between this and that. So I mean, there are strict contraindications, but there are relative contraindications. And we should really know the block print from the small print. The other thing is, you know and I know that one of our colleagues has always presented a case that had a ruptured posterior capsule in a patient that had a trifocal intraocular lens in the other eye, and he was scheduled for this eye, and he had a ruptured posterior capsule. And so he implanted a one-piece acrylic trifocal intraocular lens in the sulcus. So it's all the sins together, okay? And he's reporting that this patient is doing absolutely fantastic. So I'm not advising that we all do this, but I'm just saying that maybe some of the contraindications that we abide by are a little bit too much emphasized or overemphasized.
شكرا. شكرا. Thanks, Dr. Yahya. Good evening, everybody. When I find that when we start, you can find that the rupture posterior capsule can happen at any stage. So you can find something like that if you are not having a good tightening of your slow motion of your cannula. You can find how it goes like a bullet. How fast is it? You can see now. Then, what's the problem now is it just hit the side, and what will happen? I hope that if you have your retina assistant, he should examine the retinal periphery. You might have a giant retinal tear, but thanks God, just I have a small part of the vitreous, and everything is going okay. You can see the particle of the vitreous gum now. You have to look carefully before you're doing a case because rupture of posterior capsule, you can start from the anterior capsule. So sometimes you have an abnormal incision, abnormal adhesion or attachment from the anterior capsule for the zonule. You can find this can, if you are accustomed to do your rexes very smoothly, but you can find this filaments of these zonules are just having these adhesions, and you have to be careful about this case, maybe have subluxation or something abnormal. As we said, video please. So you have to be careful while doing your phaco, because this might end like an iatrogenic. You can find that the bag is coming suddenly in your phaco handpiece, like this case. Because if we just repeat what's going on in the beginning, you can find this corrugation. That means that you have some sort of zonular dehiscence, so you lose the stretchability of the capsule. So you can use this, in this case, you can use a CTR or a capsular hook syndrome or capsular tension instead of capsular tension rings. Anyway, if you just see this video, you can find how the capsule or how the zonule is very powerful. As it's video, please. While I'm doing IA in a young patient, you can find how the bag just be caught in my hand, and how the zonule is very powerful. You can see the recoil of the zonule, how the recoil. So maybe I have to put in a CTR in this case, or use a 3-piece IOL, put it directly on the area of subluxation. You can find a case vitreous without, rupture posterior capsule without vitreous. And in such case, while doing an IA, and how to be sure that you don't have a vitreous in the anterior chamber, that you find that all the dynamics is going in the same way. Like here, everything is going good. The flow dynamics in the anterior chamber is good. And you find, I just noticed that I have a ruptured posterior capsule here. You can find it's rolled. So how to be sure that there is no vitreous? If you find that the flattering of the posterior capsule is just a flattering while you are having your IA, never go out. Firstly, then you can continue the case, and you can find it's rolled up and it's not stretched, not curved. So that means that you don't have any vitreous, so you continue, because at any time you go out, you will find that the vitreous, anterior vitreous face will open. You can see how the freely mobile, then you can continue the case. You never go out until you inject viscoelastic inside, as Dr. Yahya said. Maybe in this case I can't continue posterior rexus because I have a big opening in the posterior capsule. So you can implant in the sulcus with optic capture lens. Everything is not doing in the same way. This is the goal for Mohamed Salah when Egypt just reached the World Cup in 2018. Then rupture of the posterior capsule can happen at any time. Like this case, you might have a high flowability, just lowering, or maybe in the primitive machines you can find that there is no active infusion. Then you can find. So all what you do is you have to just never to go out. Just continue like here, it's a slow motion, you can find. All what you have to do is just continue the case, never go out. This is the message, just implant and you can continue the case. You can do it posterior rexus, or you can never go out, as we said, and you can continue the case. So not every case goes, the solution is the same, because this is Mohamed Salah also in the Premier League. He just kicked the goal in the same way that he kicked it while Egypt with reaching the final in World Cup in Russia. But the same way he shot it, but it's not kicked inside the goal. So you have you don't have the same way to solve every problem. So in this case, I just white cataract, maybe a nuclear grade 3-4, doing the groove, making the groove and trying to quick shopping. And I find that while I'm doing the shopping, the two halves is not coming back. So I just have a doubt that I have a rupture of the bag. So I have to be careful that if I go inside again, I will find one of the halves going down. So I have to do an assisted levitation to elevate, to take it out. I widen the wound and take it. There is a lot of solution. You can do a scaffold technique, but this case wasn't able to have a scaffold technique, and you can implant a 3-piece IOL. Sometimes you find the vitreous is coming to you after implantation, like in this case, you finished everything, and you just put the IOL, and then, you can find that after I put the IOL, this case was doing RK before with a very hard video, please. Then after implanting the IOL, I just looked to the nurse. I didn't recognize that I have a vitreous is coming out. Now we can find the vitreous after implantation, that you find the vitreous is coming out. The problem is you shouldn't go with the IA, because IA makes more hydration to the vitreous, and you will find the problems goes more and more outside. So first of all, do vitrectomy, and you can put Ahmed segment, and there is a lot of solutions, not the way to talk, but when we go back to the case was very hard in nucleus with a 75 years old man. That's why you have the zonules, as we said. The zonules is getting weaker after 50 years. Every 5 years you lost about 0.5 millimeter from its stretchability. So I say that in this case it's better not to do phaco, or you can be more careful and careful. Scaffold technique that we talk about, like in this case, I have a 1/2. Turiha, there's somebody behind me, or it's okay. So you find that you have a lot of, still have 2/3 of the lens is still in the anterior chamber, and you find that you have a problem in the posterior capsule. I didn't recognize now, until now, everything is going okay. The first thing that you find that you have a problem, that you find that the dynamics is not going in the same way. So it's better to implant an 3-piece IOL just to prevent this lens from falling down. You can find this is a big hole inside. Just inflate with viscoelastic. You can implant the IOL here, and then you can continue. You might use, if you have a good machine, you can use the same parameters, but sometimes you're working near and near to the cornea, so it's better to have lower power parameters. Then you can continue the case and put your IOL here. Also this case with, in this case, it was hard lens. You have to be careful and don't move. You have to adjust your power exactly like your movement of your hand, so you don't do more and more stress on the lens. Trying to, it seems it's a white cataract, but still it's a very thick lens, so the vision doesn't want to continue. So I try to rotate again and again, and I try to divide the lens. Don't divide too early, because I still have the main bulk is mainly in the lower part, so not in the upper part. So you just try to rotate more and more rotation to debulk, to do divide and conquer. In this case, I don't used to do this technique, but I try, but I didn't. I wanted just to divide because I know it's a bulky lens. I try to do, but suddenly I find that I have a problem, because that we call the pupil snapping sign. This is the pupil snap sign. What's a pupil snap sign? That means that you have a vitreous coming from the zonule. You don't have a ruptured posterior capsule, but you have a. So how do you differentiate between ruptured posterior capsule and this? Because when I just wondering what's going on, so I go out and just posterior lip. I just push the posterior lip. The anterior chamber gets more to get shallow. If it didn't get shallow, that means you have a vitreous. So I continue the case, but the case, I just recognized lately that this is not a ruptured posterior capsule, but what we called pupil snap sign. So now in this stage, I just recognize that I am just taking vitreous in my phaco handpiece, like this. At this time, just now I recognize that I have a problem here, then I go out. So this is the pupil snap sign. This is the pupil snap sign. That means you have a vitreous coming through the zonular dehiscence. You get the bag outside, but you still have an intact posterior capsule. This is a slow motion about the snapping sign. So you can manage the case with the ruptured posterior capsule. So it happens to me again, then I understood, and that's why video please. That's why I take decision to convert the case or to have the solution early. So snapping means the flattering of the iris. Just this is the snapping sign that you find that the dilatation of the pupil, and just suddenly, so I convert, because this was one-eyed patient, so I was afraid to do the tumbling of the lens, and I continue the case. This is the slow motion of the snapping sign. I was pushing by my other hand because the pupil wasn't narrow, then I decided that's a snap sign, so I have to go out. So finally, this was my first case. I never forget this case, the sunrise case I saw. I hope nobody faced this, but after 10 years of working, I faced another case. So I never forget these two cases, because this was a very simple case, but he was exhausted. just thinking about the other case, what's you going to continue your day, and everything is going like this. I hope nobody faced this. Always look not to forget, and thank you very much.
شكرا جزيلا، يعني كمية حالات رائعة. Still have some time for discussion. مش كده يا دكتور عبد العزيز؟ دكتور أيمن.
I want to ask you about halos. Did you try the precision lens? Precision lens. With the precision lens, I implant a lot of trifocal nowadays, especially even in ladies who are 50 or 60 and having +2, +2.5, +1.5, and they are not happy about using the distance and the near lenses, glasses, I mean. So just correcting presbyopia and treating this mild cataract. And the ladies are very happy. And this lens, in fact, is very forgiving when it comes to halos. Unlike for example, I was using the Physio lens, and really I had trouble with some patients. One of my patients still have halos. I've done him the surgery 3 years ago. I want to ask you about your experience with halos, with trifocals.
With the trifocal intraocular lens, it's inherent that the patient will have night halo, especially if he has a wide-ish pupil. But the thing is, any patient, when you tell him pre-hand that he will suffer from halos, which is not a handicapping thing unless he has a night vision job, like he's a truck driver at night or something. But otherwise, when patients are informed pre-hand, I have yet to see a patient that was troubled by the halos. They always say, yes, we see what you meant, but it's not handicapping. The problem arises when something happens that the patient did not expect, or you did not inform the patient preoperatively that it might happen. Then he will definitely think that something is wrong, and he will seek opinion of other doctors as well. So yes, after trifocal intraocular lenses, not some patients, all patients, if they are good observers and they take a look at a point source of light, they will see some halos, and this is inherent in the optics of the lens. But a very, very limited amount of patients are really bothered.
شكرا دكتور دكتور اتفضلي.
No, I don't implant trifocals in keratoconus at all. I'm just saying that there are studies that are reporting good results even in documented keratoconic patients. But again, these studies were done on like 10 patients, 10 eyes, actually not 10 patients. So still this is a long way ahead. But, and I'm just saying that implanting a trifocal intraocular lens in a patient that has documented keratoconus has been always considered as a crime. So this doctor should go to prison or be killed. And these are patients that has been done by reputable doctors and reporting good visions. So this is something just food for thought. So we should really investigate more and know exactly the higher order aberration that we should not that we should not implant trifocal intraocular lenses in.
This is the first point. Second point, usually you said you trigger emitrope or hypermetrope. But in keratoconus, you know, we try to triggering myopic. To leave the patient myopic according to the stage of keratoconus. So if we are deciding to do multifocal in keratoconus patient, we trigger what?
Don't decide. Don't take this decision yet. Okay, so, but keep the thought. Maybe you'll use it a couple of years ahead.
Thanks a lot. please. Sure. Thanks a lot.
Dr. Ahmed Ounin, if you have a posterior capsule rupture and you see it and there is vitreous and you're doing phaco in the last quadrant, for instance, would you continue phaco or what you would you do?
If I find vitreous in the anterior chamber,
In the last quadrant.
no, I mean, I never put the phaco handpiece until I find the vitreous, but I can continue in 2 cases if I'm sure that the hole in the posterior capsule is away from my working area. For example, it's a sub-incisional and I have to do good vitrectomy to push the vitreous down, or I can do visco-expression, or I can do the scaffold technique. This is my opinion.
Thank you.
Dr. Ayman, I totally agree with you regarding the precision lens. I experienced the precision lens for my patient. It's written in literature that is the mode of action is different from EDOF, as you know. It's a continuous transitional focus. So in each segment, there is correction for near and far. So it's less pupil dependent, okay? Is more giving, yes. Even me. My mother has implanted this lens and she's very happy. She used for near, yani she's mobile dependent, okay? Yes.
There is also the Synergy is a continuous focus lens. Synergy of J&J also. But of course they will see halos and it's not forgiving lens and you have to be accurate on the biometrics. In general, in all materials.
Another question for Mohammed, please. So you said that we can use the multifocal after the LASIK. Is it the same if the patient was hyperopic or myopic, the same?
The challenge has always been in myopic LASIKs. In hyperopic LASIKs, they were never an issue. And people would implant trifocal intraocular lenses, bifocal intraocular lenses, whatever lenses they want after hyperopic LASIK with no trouble at all, because there was never reported a hyperopic surprise, a refractive surprise after implanting an IOL in a hyperopic LASIK patient. But the problem was definitely in the myopic, in the patient that had myopic LASIK before. And from the repeated results of many studies in the literature now, that you implant in these patients, provided that you don't have higher order aberrations from the anterior surface of the cornea, and you do have a regular ablation from the previous surgery.
And
Okay, any questions?
yeah, it's just a comment on the premium oils. If you have a decentered ablation in post-refractive and you're going to do a trifocal, it's not recommended. Also, severe flat corneas and very steep corneas, also it's not recommended for trifocal. You can go for EDOF, it's better than trifocal.
Okay, thank you. Any more questions? By this we can conclude if there are no more questions. Thank you for the speakers. Thank you.